get started right now. Thank you all for joining us today. Welcome to our webinar, A Brief Overview of Opioid Use Disorder and Implementation of Medication for Addiction Treatment in Nursing Settings. My name is Irene Valdovinos, and I am the training coordinator for the PCSS, Provider Clinical Support System grant here at Azusa Pacific University, APU. I like to start off by briefly sharing a little bit about our PCSS grant here at APU. So our project here at APU is a collaboration between Dr. Rachel Castaneda's team in the psychology department and the APU School of Nursing Nurse Practitioner Program, which is overseen by our co-director, Dr. Linda Reed, and our community partners, also UCLA, who you'll hear from two of our partners from UCLA today, and also experts in the MAT implementation field of practice. The PCSS grants are funded through a grant by SAMHSA, the Substance Abuse Mental Health Services Administration. They fund various projects across the US as part of this initiative to expand practitioner education focused on medications for addiction treatment, which we'll cover today in today's webinar. And also, just so you all know, today's webinar is part of a three-part series that focuses on implementation of MAT in nursing settings. So the speakers today are from UCLA, Dr. Sherry Larkins and Ms. Kendall Darfer, both which have extensive experience in the areas of MAT implementation and integration within healthcare settings. Before I hand it over to our presenters, I'm briefly going to go over some quick logistics. So you'll see here on the slide, if you're receiving continuing education credits for today's webinar, please note that you must attend the full duration of the webinar and then complete the training evaluation survey at the end. So the link was emailed to you earlier today, and prior to this, it was emailed prior to the start of the training, but we'll also pull up the link at the end of the presentation. And we just recommend you complete your training evals within a week of today's webinar. That way you can get your CE certificate or certificate of completion within the next 2 weeks. So also please note that the webinar is being recorded. So we have most of you on mute today. And we do want to make this webinar available for those who are unable to join us today. And we do have 2 other webinars that we'll be offering this year. So look out for those training announcements. We'll mention them briefly toward the end as well. And during the presentation, if you have any questions or comments, please drop them in the chat. And during certain points, we'll review and make sure to answer them. For any technical questions, you can drop a chat message to the Castaneda research team, who's also co-hosting us. That's Ashley in the background helping out with tech. The next slide here quickly shows the objectives that we'll cover in today's webinar. So I'll now go ahead and turn it over to our first presenter, Ms. Kendall Darfer.
Thanks, Irene. Let me pull up my slides here. So yeah, I'm Kendall Darfler. I am the project director of the evaluation of California's state opioid response program, which is a statewide response to the opioid overdose epidemic. So today I'm going to be sort of introducing the talk by going over just sort of the opioid overdose crisis within the California context. Okay, so the opioid overdose death rate in the state of California has been increasing pretty rapidly, especially over the last few years. As of the end of 2019, statewide opioid-related overdose death rates had risen from, risen to 7.45 per 100,000 residents. And while this is lower than some of the other states that we hear about maybe in the news that are at the center of the opioid epidemic, our rates are only increasing more and more rapidly with each year. And one thing that's pretty concerning is that this increase is probably driven in part by the growing use of fentanyl in the state. So for those who haven't heard of fentanyl, it's a synthetic opioid that is 50 to 100 times stronger than morphine. So really, really strong. And because it is so potent in small doses, it can be a lot cheaper than other drugs. It can also be easily mixed into heroin, counterfeit pills, and other drugs like cocaine and amphetamines. And sometimes this is done without the knowledge of the person using those other drugs, which, as I'm sure you can imagine, has made it a pretty major driver of overdose death rates throughout the country. And you can see the data here from the CDC. So fentanyl has been talked about quite a bit in the news as a major factor contributing to the US overdose crisis, particularly in the eastern states where it first took hold. But as you can see in this next graph, the overdose death rates due to fentanyl have been following a very similar trajectory in the state of California to that of opioids overall. So I think a lot of people have been like taken aback by this because fentanyl really seemed at first to be pretty isolated to the East Coast, which oftentimes was attributed to the differing drug supplies on the different coasts coming from different parts of the world. But what we're seeing now is that the West Coast was kind of just a few years behind. So while we've had some more time to prepare and launch initiatives to increase access to treatment for opioid use disorders, which I'll talk about a little bit more in a moment, we're still being struck with this public health crisis in a big way. And the presence of fentanyl in California is just really spiking death rates very high. And this is impacting communities of color the most, particularly Black and Native American residents. So in national news, we typically hear about the opioid epidemic affecting mostly white populations. But in California, communities of color are actually experiencing the crisis equally, if not more. So overdose death rates in the state have always been highest among Native American residents, but rates are actually rising most rapidly among Black and African American residents. So in 2018, this graph looked nothing like this. In just 1 year, the opioid-related death rate among Black residents nearly doubled. And as you can see here, fentanyl deaths actually had a pretty big role in that. The fentanyl death rate for Black California residents was 7.2 per 100,000 in 2019. And as I mentioned before, part of that problem is that fentanyl can be mixed into other non-opioid drugs with or without the knowledge of the person using them. And I think we may be seeing evidence of that in these increasing rates of overdose death due to a mixture of opioids and stimulants. So these are the rates for a combination, the blue line, of opioids and any psychostimulant. So that's things like methamphetamine. And then the orange or yellow line there is opioids and cocaine. And we can't know this just from these data. So I think we need to do more research about whether people know that they're taking opioids or not, right? So polysubstance use, and especially the presence of fentanyl in opioids and other drugs, is really a growing public health crisis that's highly affecting communities of color in California, and is a problem that needs to be urgently addressed by public health workers and policymakers and clinicians as well. So the California opioid crisis also looks different in different areas of the state. As you can see from this map of the 5-year average overdose death rates, the rural northern counties have the highest rates. But if you can see, I know it's kind of small, San Francisco actually has a very high rate as well. And rates have also been increasing over just the last couple of years in Los Angeles. So this is the 5-year average overdose death rate in Los Angeles County by zip code. In the last year, overdose death rates in LA County have increased by about 60%. And this shows on this map where those deaths have been most concentrated. So Antelope Valley has had multiple years over the last 5 years with extremely high overdose death rates. That's that sort of bright red spot here, driving their rates way up to on average 93 deaths per 100,000 per year. And if you zoom in on this map more to the city of LA, you can also see very high rates in downtown LA, which has annual rates between 20 and 48 per 100,000, and Santa Monica, which downtown Santa Monica also has average rates of about 20 per 100,000 residents per year. So these areas overlap a lot with where many unhoused residents live. As someone personally who has spent some time doing outreach and Narcan distribution in these areas, I can say that overdose prevention and harm reduction services are highly needed in both of these locations, but also throughout the whole county and the state as well. So, you know, harm reduction and overdose prevention has definitely been a big focus for the state of California in addressing the overdose crisis. So starting in 2017, the state received federal funding from SAMHSA to put into multiple projects to address opioids. You can see here 30 projects. One of the biggest investments that California made was in the naloxone distribution project, where in the first 3 years of this grant, they distributed over 450,000 Narcan kits around the state, which led to 19,000 documented overdose reversals, and probably a lot more that weren't captured by data collection. They also put money into about 25 other projects that had the aims of increasing access to medications for addiction treatment, or MAT, reducing unmet treatment need, and reducing overdose-related deaths. In combination, these projects created 650 new access points where people could get medications for substance use disorders, 12 of which were Indian health programs who specifically provide treatment to Native American communities. And then the project that I mostly worked on up until this point was the Hub and Spoke program, which created a network of specialty substance use treatment providers and primary care providers who were able to prescribe medications for addiction treatment to connect with each other and create this sort of network of expertise to expand medication access. So in that project alone, the participating sites started over 30,000 new patients on MAT for the first 3 years, and probably a lot more to come over the next 2 years that we're funded for. And other projects started an additional 6,000 patients on treatment. So that's all, you know, highly needed, and it's fantastic progress. Clearly, there's a big crisis that needs to be addressed. But based on those charts and graphs that we saw earlier, there are still some gaps remaining. So in our evaluation of the Hub and Spoke project, we really did like a patient-centered focus on treatment access. So some of the gaps that we're still seeing are in those rural northern and central valley areas of the state where there's just less access to treatment overall. People have to drive really far. There's limited transportation options and just fewer treatment sites in those counties. Many counties also have limited access to one of the medications, methadone, which is much more highly regulated than medications that can be prescribed in primary care settings. But because methadone has been around a lot longer, a lot of patients really prefer that. And so not having it available in many counties leads a lot of people to just not get treatment. There have also been issues with telehealth, and we've especially seen this during COVID-19. Every clinic that we worked with adopted telehealth in the first few months of the pandemic. But there are still these gaps because a lot of patients lack reliable phone and internet access. And as of 2017, 26% of California households lacked a broadband internet connection, with larger gaps among low income, less educated, rural, African American, and Latinx households. So even though telehealth has the potential to really expand access to medications, there are still some disparities there that need to be addressed. We also saw issues in our evaluation with the appropriateness of care. So, patients weren't getting maybe the quality of care that they expected, or they weren't being connected with the resources that they felt they needed. And this really impacted their engagement. So patients who didn't feel that they were getting what they needed because of maybe a lower quality of care left or switched treatment providers, which impacts the continuity of their care. And there were also issues sort of across all sites that we interviewed patients from with dosing requirements. So there's a lot of rules around what patients have to do in order to get their medication doses, which, no medication should be tied to the types of restrictions that medications for addiction treatment are. There's also quite a bit of stigma from providers towards patients with substance use disorders, long wait times, and again, quality of care problems overall. I'm sorry, there's a fire truck going on. All right, Zoom problems. So on the note of provider stigma and quality of care that really impacts patient engagement and ultimately down the line access, I wanted to leave everybody with this quote from a patient that we interviewed who actually had a really good experience, but compared that to some of the experiences that they had had in the past. So they said, if I could say one thing, it would be more people with addiction would be prone to actually seeking treatment if they had a provider like mine, who in the easiest, softest way and in the fewest words, pretty much convinced me that I was worth it. I feel like if more of the providers that participate in this program could see people in my shoes as not just, a low life, if they could see us as people too, there would be a lot more people walking in off the streets wanting to get help. I mean, she generally cares, and I've never seen anybody practice medicine like that. That's all I can say. So that's kind of the end of my slides. I don't know if anybody has questions about what's going on in California, or if we want to move on to Sherry's slides.
Great. That's a good opportunity to, as I'm sharing mine in the chat box, to ask any questions. Kendall, can you see my slides?
I can, yes.
Okay, all right, perfect. Thank you, Kendall. That was awesome. And it really set the stage for, I do see actually a few, so I'll let Irene or team kind of check out the chat if questions come up. One of the things that Kendall did was really set the stage for the great need that we have, not only across the United States, but definitely in California and especially in our area, with really needing to develop a workforce that is responsive. And I think that last quote highlighted that when we have a workforce that's responsive, people get better care, they get better access to care, they get better quality care. And I would say it was probably about a decade or two ago that specialty substance abuse treatment really started shifting and realizing that the primary healthcare system is really how we're going to have to change access to care. That we can't expect that people who really need services are always going to find their way to the very small sliver of services that are available in care. So probably over the last decade or so, we've really tried to shift in order to provide more integrated care, and medications for addiction treatment are really in the domain of the medical system and in community health settings. And so part of all of your training right now is getting trained in getting waiver trained, and so that you'll be able to finish your program being able to prescribe buprenorphine. And so it's only been probably in the last few years that nurse practitioners have been added as one of the key personnel or key workforce that are able to prescribe medications for addiction treatment, and in particular buprenorphine. And so it's one of the kind of focal points of this grant is really to ensure that people understand in their training as nurse practitioners a little bit more about substance use disorders and the medications that are available to treat them. So what I'm going to do is, as Irene said, we kind of have a series of trainings that are, or presentations conducted by physicians and nurse practitioners that will really focus on the buprenorphine and how it works and how it can be incorporated into practice, and what you as a nurse practitioner kind of will need to know if you're working in settings where you treat patients with opioid use disorders. And what Kendall and I are doing today is just kind of providing a little bit of the bigger picture of this is the need that we have in the state, and these might be the settings that you're entering upon graduation, and these are the patients and the patient population that you may be seeing. And these are some of the latest medications that are available to you as a prescriber. Although we focused on opioids, because opioids is really sort of more critical, and it's really sort of the crisis, at least in terms of sort of the national crisis. But we also know that that one of the big issues in terms of addiction medicine is alcohol. Alcohol and tobacco are really the drivers of sort of, I guess they're the kind of bread and butter, if you will, of substance use disorders. And from a public health perspective, alcohol and tobacco are really what drive health problems. But there are medications for opioid use disorders and for alcohol use disorders. And we sort of, under this umbrella of medication-assisted treatment, we thought we would sort of set the stage of both alcohol use disorders and opioid use disorders, since those are kind of what you will generally see in community health settings. And that we would talk about the medications that are responsive to those two disorders. So I'm going to walk through that today over the next few minutes. And then just also as a note, in California, we do see a lot of stimulant use disorders. And as of yet, there are no medications that treat stimulant use disorders. So what you'll see embedded into primary care and community health clinics is for what we call MOUD, medications for opioid use disorders, and MAUD, medications for alcohol use disorders. So I'll just go through, there we go.
Sherry, do you mind showing it in presenter mode?
Am I in presenter mode?
Yes, now it is. Thank you.
Okay. So Kendall hit on the opioid use disorders and kind of really the pressing need that we have here. And some of how we got here in some ways is, I like to show this, I medicate first and ask questions later. So we know that there have been overprescribing issues for several years that have gotten us into a state where we now are really trying our best to provide the necessary evidence-based services to those who have developed opioid use disorders over the last few years. And one of the things that where kind of the medical field or nurse practitioners in particular are really sort of driving the care of people with substance use disorders is in kind of shifting from this sort of, psychosocial treatment of addiction to really biopsychosocial. And so we say to every complex problem, there is usually a simple answer, and it's usually a wrong answer. So one of the things that we know is that medications have pretty robust effects in terms of the long-term outcomes for people. So for people who are getting counseling and getting therapy for a substance use disorder, when they add medications to their overall treatment plan, their long-term outcomes are much more enhanced and they're much better. So the more that we can build capacity within the primary care system, or bring healthcare capacity into the substance abuse system of care, this is where we're going to sort of marry the best science to provide services that are maximized for our patients. So there are several medications for addiction treatment that are safe and effective, and that have robust research supporting their use. And in the last decade or two, they've been used better. And one of the project that Kendall is on in particular is pretty compelling, that we've been able to not only support and provide training for prescribers like all of you, but being able to sort of train a workforce that now is responsive to patients and their needs. And in the state of California, we saw, as Kendall mentioned, thousands and thousands of patients who now have enrolled and are receiving, better quality care and have improved access. When we think about the medications for addiction treatment, and I'll kind of go over what happens when you drink alcohol and how the medications that are prescribed for alcohol use disorders, what are they doing to sort of, in a way, address the kind of neurochemistry, if you will, of alcohol use disorders. And for opioid use disorders, I'm going to do the same thing, is kind of walk through, this is what's happening when we're using opioids, and this is how the medications are responsive to kind of those neurochemical changes that are happening. So in kind of this intoxication cycle, and in some cases when we think about a cycle of sort of developing a substance use disorder or an addiction, there's a couple of places where medications can help address. And the first area is really in, we know that over repeated use of a substance, there are particular changes in neurochemistry that we increased pleasure. In some cases, it's just sort of relief. At some point, maybe you're just using a substance to not go through withdrawal. Maybe you're not even getting so much pleasure as much as you're just avoiding pain in some ways, and avoiding the sort of withdrawal. Medications can kind of focus on that sort of relief and that sort of pleasure area, and they can also focus on craving. Some of the medications that we have specifically address the craving response, and they kind of target craving. So we tend to think of in this kind of this whole person care. We have these sort of, we always talk about a biopsychosocial and really a spiritual approach. And I think it's one great thing about Azusa Pacific has been pretty, Dr. Castaneda and Dr. Reed and their team have been really good about also sort of really incorporating the piece of spirituality that many people who feel that they've been broken through substance use disorder. And we've, in science, we often focus on these biopsychosocial, and, I think in some ways, faith-based universities have done a really good job of trying to sort of bring in that spiritual component that often gets lost when we're just sort of talking about sort of the scientific piece. But medications for addiction treatment, as you can see in this slide, is really about the kind of that biological piece. And we don't have any medications that are total silver bullets. You're not going to swallow a pill and suddenly not have craving and feel relief and your life gets put back together. But what medications for addiction treatment tend to do is they kind of loosen up and target that unnatural grip that substance use has on some of your neurotransmitters. It kind of makes things it tones some of this down a little bit to allow you to better tap into the psychological, the social, and the spiritual aspects of your recovery in a way that is a little bit easier. So when we think about the types of medications for addiction treatment, there are a few, as I mentioned, that are focused on alcohol use disorders, and some that are focused on opioid use disorders. And today we're going to talk about both, but through the rest of the kind of series that we have, where we'll have, Dr. Brian Hurley and Dr. Matt Torrington, we'll have a couple of nurse practitioners that specifically have worked for a long time with buprenorphine. In this series of presentations that we provide over the next few months, you're going to see us really focus more on buprenorphine. And buprenorphine has really been kind of at the state level been promoted because it integrates so well into primary care settings. And it is also, as you guys are getting waiver trained, it's the medication for addiction treatment for opioid use disorder that you guys are specifically learning more about. So as we walk through this Disulfiram, some of you have heard about it. That's Antabuse. It's one of the oldest forms of medications for addiction treatment for alcohol use disorders. We'll walk through a Acamprosate, which is also known as Campral, for an alcohol use disorder, and naltrexone. Naltrexone comes in various formulations, including a long-acting 1 month injectable, which is called Vivitrol. You'll notice here that naltrexone is also used for opioid use disorders. So there are data to support it using for both alcohol and for opioids. And that's because naltrexone actually works on sort of the pleasure principle. It works on sort of opioid receptors and euphoria, and sort of some of the, it kind of blocks some of that sort of pleasurable experience that you receive from substances. So it tends to work on both both substance use disorders. We'll also briefly talk about methadone, and then we'll end with buprenorphine, which is kind of where we launch for the rest of the series, is talking more about specifically buprenorphine. So when we look at alcohol use disorders, alcohol use disorders is probably, of the patients that you see, we know that alcohol use, because it's a legal drug or a legal substance, it does tend to be the substance for which most people present a substance use disorder with, is alcohol use. And for our purposes, when we think about how alcohol works, alcohol is like it's a user-friendly substance. It likes lots of neurotransmitters in our brain. There are some, opioids or stimulants that kind of target and work more specifically, but alcohol sort of taps into a lot of our neurotransmitters. And we talk about it, it touches on opioids, our endogenous opioid system. That's where pain killing happens. Painkillers touch on your opioid receptors. It's also where people feel euphoria. You see dopamine listed here, and dopamine is a neurotransmitter that is very much in play with all substances of choice, whether it's opioids or stimulants. Release of dopamine is characteristic of sort of developing a substance use disorder. Big releases of dopamine, we call it a pleasure chemical. It's more than just a pleasure chemical. It sort of is satisfaction. It's in some cases elation. And I think probably the most important thing about dopamine is that it's actually the neurotransmitter of salience. So it is it's the wow. Salience is something that you remember because it's special. And dopamine in sort of a high output provides people with that, wow, this is something I want to remember because it feels different or it feels special. And then the two neurotransmitters that are constantly kind of battling or bickering here with alcohol are glutamate and GABA. And GABA is really a down, it slows the system down. It's a neurotransmitter that's inhibitory. It kind of slows you down. As you know, the more alcohol you drink, it kind of is a sleepy neurotransmitter. And in a response to that down regulation, glutamate constantly increases. So glutamate chases GABA. If GABA is bringing the system down, glutamate is increasing so that the brain can get some sort of like homeostasis or some sort of balance. And how this works is you have alcohol, you drink a little bit, you know, your first beer or your first cocktail, you are feeling a little bit good, you feel relaxed. This is all this sort of the endogenous opioids, and then kicks in a little bit of dopamine, like, wow, that feels good. I feel relaxed. I feel, you know, maybe a little bit of pleasure. And this is kind of a reinforcing behavior. But what happens over time when people start to sort of drink and you drink too much, GABA kicks in, and GABA slows the system down. So this is kind of, GABA is what we have to be concerned about when people are like have sort of alcohol, kind of alcohol poisoning, or they drink too much where they slow the system down. And what happens is the more we drink and GABA is sort of enhanced and we get sort of tired or sleepy and we slow the system down, a response is increase in glutamate. And glutamate is an excitatory response. So it's kind of trying to keep the system up. And what happens over time when we drink, you see this issue of tolerance develop. This is how tolerance comes about, is when the more you drink, the more GABA slows you down and the more glutamate starts to increase. And so over time, you see this kind of dysregulation between GABA and glutamate. And so for most of us, our system is like GABA and glutamate are constantly in balance or pretty close to it. But when we drink, we see that we get excess GABA. And so we're actually sort of weighing our system down. And in response, we have glutamate that increases a lot. So we have this now, glutamate responds to GABA and drinking. And so what happens here is, in the absence of alcohol, so when you do take alcohol away from a system that now has sort of re-regulated itself between its GABA and its glutamate, you have, you know, what we often call sort of withdrawal. And some of the medications for addiction treatment target specifically this issue of the imbalance between GABA and glutamate. So if we're looking at withdrawal here, you can imagine that we have too much glutamate now. So this is someone who has stopped drinking, but probably has an alcohol use disorder. This is the person that in the morning they wake up and they want to take another drink. And the reason why they want to take another drink is because there is an imbalance of their glutamate. And if you remember, I said glutamate is an excitatory response. So this is the irritation, the agitation, the jitteriness that happens when someone has developed an alcohol use disorder and now is sort of too much glutamate now that they've removed alcohol. And so you can see how, you know, people start to crave that which restores their balance, which would be drinking alcohol is going to restore the GABA glutamate here, or in some cases a medication can help. And this is where a medication called Campral comes in. So as I mentioned, these alcohol use disorders, they either reduce your withdrawal symptoms, maybe they block euphoria, or in a case like Disulfiram, they really just make drinking so awful that you don't want to do it again. They kind of work on aversion therapy. So here is Disulfiram, or sometimes called Antabuse. It's not used as much anymore, but it is certainly used in some settings. And for some patients who are highly motivated, they still will use Disulfiram. And it does have a profile of helping or supporting patients in the long term. And Disulfiram works in a different principle. Rather than a Campral that kind of restores GABA and glutamate, Disulfiram works purely on kind of making us not feel great when we drink alcohol. And so I'm going to walk you kind of briefly through what happens when we drink, and how medications can kind of come into play in helping patients who have developed an alcohol use disorder. So first of all, we see over here.
Sherry, you're muted.
Sorry. Can you hear me now? Okay. So when we drink alcohol, there are two neurotransmitters that come, two enzymes that come into play when we drink alcohol. The first one is alcohol dehydranase. So we drink alcohol, immediately an enzyme comes in and starts breaking down alcohol, and it breaks it down into acetaldehyde. And for all intents and purposes, acetaldehyde is basically poisonous. It's, you know, it's not great for us. Acetaldehyde dehydranase is another enzyme that quickly kicks in and breaks acetaldehyde down into acetate, which then is broken down into water and CO2. And then it's eliminated in the body. For many people, some people have a natural allergy. They call it sort of an allergic response to alcohol. And in some, those are people who actually have a very highly efficient form of the first enzyme called alcohol dehydranase. That actually is an enzyme that's disproportionately seen. That enzyme, the highly efficient version, is seen disproportionately in some populations, including Asian populations, tend to disproportionately have a highly efficient form of alcohol dehydranase. And when I say it's a highly efficient form, people say, I feel sort of allergic when I drink. I get flushed, I get red, I get sweaty, I feel uncomfortable. And those people tend not to be big drinkers because alcohol is not pleasurable for them. That highly efficient form breaks it into alcohol into acetaldehyde so quickly that they start to get sick pretty quick. Whereas most of us who enjoy a cocktail now and then, are the pacing in which that enzyme works, it breaks alcohol into acetaldehyde in a way that is kind of, we never get acetaldehyde buildup unless we're drinking way too much. And it's the buildup that is the problem. One of the medications for addiction treatment, Disulfiram, it works by actually addressing this second enzyme, acetaldehyde dehydranase. It makes it very inefficient. So what it does is you get a similar response as you would if you were allergic to alcohol. It kind of makes people stay in it makes acetaldehyde buildup in your body. And whether that happens naturally or whether it happens through a medication, the result is the same, which is that it's very uncomfortable to drink. And so this is one of the early medications for addiction treatment, is that it creates 5 to 10 times higher amounts of acetaldehyde in the body. And people feel a lot of uncomfortable responses. And they say that they feel uncomfortable. Sometimes they vomit, they feel nauseous, they feel sweaty. We call it a flushing response. They report being weak or thirsty. And there are a number of, a variety of symptoms associated with it, which tends to make people, and you notice the last one says death. So yeah, we don't like that. We don't like to kill our patients, but so it is one of the early medications that people use because patients found it very uncomfortable to continue to drink. I mentioned Campral, or a camprosate, and that is the medication that specifically targets GABA and glutamate. And so what Campral does, or a camprosate, is it really tries to re-regulate under sort of normal there. I put the A, and that's really what happens when you bring the medication on board. There's this re-regulation between GABA and glutamate that happens with that particular medication. And again, none of these medications are total silver bullets, but they do lessen some of the kind of craving or some of the pleasure that one experiences when they drink. And the last one is naltrexone, or we sometimes say Vivitrol, because Vivitrol is the long-acting injectable, which benefits many people because you have the medication on board for a month straight. So planning a relapse or planning to use substances, you just have to put a lot more thought into it because you actually have a whole month of medication that's in your system. And during that month, what's essentially happening is the pleasure, we say it takes the kind of the party out of the can. It takes the pleasure out of drinking. It doesn't mean that people don't feel something, but they just don't feel as much. It's just not as reinforcing. So the idea of, working on those opioid receptors and those dopamine receptors, it just kind of tampers them down a little bit so that people don't feel kind of excited and like, wow, this feels good. Instead, it kind of feels like, meh, what's so great about drinking a 6-pack of beer? I just feel fat and bloated and I don't even feel that great. I'm not going to feel as bad as if I were on disulfiram or antabuse, but it just isn't that reinforcing. This medication also works for opioid use disorders and is a very effective medication. One difference between this medication and the other two that I'll talk about for opioids is that this medication, you have to be already withdrawn from opioids. So for people who have gone through like a medical detox or have detox from opioids, this is a good choice. And the data are pretty strong that it is almost, or if not as effective as some of the ones which work on a sort of different principle, like buprenorphine or methadone. And one of the things that we know is that the long-acting injectable does have much better outcomes than sort of the daily pill. Having a medication on board for a long time is just, it changes everything about your medication adherence. So the last section on opioids that we'll talk about are a couple of medications. One of the things that Dr. Hurley will do when he speaks in next session is he's really going to kind of go over a little bit more about what's happening in the brain with opioids and how, in particular, buprenorphine is addressing those sort of neurotransmitters. Like, what is the medication doing that makes it beneficial for patients? So I'm not going to go into that much today, but just to kind of highlight to you that that two other medications for patients besides the long-acting injectable Vivitrol are going to be methadone and buprenorphine. And Kendall talked about methadone. Methadone is a full agonist, so it sits on the receptor. It's also, you know, the great thing about methadone is it sits on the receptor. It addresses the receptor, and it hunkers down on the receptor so that other opioids can't come and take the spot. And what that means is that something like heroin use, where people's the levels of drug and go like this, in the case of something like methadone, you see it's a very it has a long-acting stimulating effect on the receptor in a very kind of low level sort of way, so that people aren't getting those really high highs and not getting like really euphoric and high, and they're not getting those lows or crashes. They're not going into withdrawal. It kind of keeps people at sort of a level amount. And one of the things that we know is that it is highly associated with good long-term positive outcome for patients, especially patients who have repeatedly relapsed, who struggle with kind of going through withdrawal and staying what we'd call clean and sober. We know that it benefits, it keeps patients alive, it keeps people engaged in treatment, it keeps people employed, and it keeps people out of jail. Overall, methadone has a very safe profile. But one of the things that Kendall mentioned is that methadone is also very regulated. Because of its kind of profile, it's very regulated by the state, and it's also not administered in healthcare settings. And so it makes access kind of different than something like buprenorphine. And buprenorphine is where we're going to be sort of spending the time in our series, because it's one of the areas where, in particular, where nurse practitioners now play a pretty big role in terms of the workforce who is prescribing and who is managing patients with opioid use disorders. And so buprenorphine can be used, there's a number of different formulations which are kind of exciting. Buprenorphine can be dosed in different amounts and in different ways. There's now like a long acting that lasts for at least a month. It might even be longer than that, Sublocade. An injectable. There's also the film. There are a variety of formulations that make it I think possible or a strong candidate for many patients. And it is used in both maintenance, like methadone, in a kind of maintenance way where you can stay on a dose for a long period of time. And it is also used in terms of supervised withdrawal. So one of the things that we'll be talking about in our next series is, you know, those patients who really want to stay maintained And that's really a lot of patients. And that's where we think a lot of patients need to be, because we know that getting off medications and on medications puts them at a lot of risk for other health issues and for overdose. But there are a lot of patients that with, good quality care and under the supervision of their doctor and under counseling, they really make the decision that they want to withdraw from all opioids. And so it can be used to actually sort of titrate down and used as a withdrawal medication as well. It is not a full agonist like methadone. It is a partial agonist. So for some patients, it's not, as we'll talk about in future series, it's not always for everyone. There are some patients that have a pretty high dosing profile of their opioid, and buprenorphine is not going to be strong enough for them. But it is a great option for many, if not most, patients who have a substance use disorder. There is a lot of research on buprenorphine. It is administered in primary care settings very well, and it has in some ways a less stigmatizing profile than methadone, because of the ability to be delivered and to have take home and to be delivered in a variety of different types of settings. And we know it's also had a huge impact on mortality. So overall, buprenorphine is a really strong, robust medication for addiction treatment that we should be considering for our opioid using patients. Thank you for your time. We did the whirlwind of medications for addiction treatment, hopefully setting us up for the next few sessions that will be more specifically focused on buprenorphine. So again, I want to thank you. I hope that you guys are interested in getting fully waiver trained. I think that when we hear from some of our nurse practitioners as well, you'll see that they feel like they're really working at the top of their license with some of these really challenging patients, but it makes their job super rewarding. And most importantly, we don't always have a ton of great advocates for this population. And so if substance use disorders are an area that interests you, we'd love to have you get waiver trained and provide you kind of the support and that you feel like you need in order to do this well. So again, thank you very much. I want to thank Kendall as well for setting up this presentation really well. Thank you, Kendall.